Geritourinary disorders. Okay. So the first thing, when we look at our kidney, we have to understand, okay, what is it all about? What does a kidney do, right? It filters. What is it filtering? The blood, right? So one of the things we remember, we say like when the kidney is filtering, 100% of the blood goes through it, but it doesn't excrete 100% of what it finds, right? It sends 90% back up, depending on if it sees that it still can use it. And then it's only 10% that it excretes in the urine, right? So what does it do? It regulates acid-base balance. And we saw that just the recent slideshow with bicarbonate. It's regulating that. If it's too high, if it's too low, what does it do? So we also see, we'll see it later. So excretes metabolic waste, so creatinine, urine, BUN, all of these things. That measurement tells us how well it's filtering, okay? So we know if it's doing it well, then like we said, a lot of the byproducts will go back, and then not all of it will be released, right? So the color of urine, the osmolality, the heaviness, right, will tell us, is it working well? Like if it's super, or the quantity of urine, all of these things will tell us how well it's working, right? So these measurements are important. Regulates blood pressure. How does it do that? Remember? Yes, the RAS system, right? And renin-angiotensin 1, 2. So but how did it notice it? Remember how it noticed it? Yes.
Quick question.
Yes.
Do you have this one unlocked?
Ooh. Sorry. I will send it.
Okay.
I apologize. I thought I had. It's not unlocked. Okay. Yes. So when we think about, so this is going to be a true view of how much you know, because you can't look. Okay. So how does the kidney know that it needs to help or, measure or regulate blood pressure? Like, how does it know to do that? It is a RAS, but what tells it to trigger the baroreceptors? Say that again? That's right, the amount of blood. So remember we said the aortic arch has baroreceptors. When it feels a stretch that, okay, I have enough blood that passed through me, so then it's like, you're good, keep going. But then if it feels, I have too much, I'm stretching too much, so then it sends signal to the kidney to do its thing. Okay, you're gonna not pee, or well, this time if it's too much, you're gonna pee more. Or don't shift the salts, because we don't want salts to come, the sodium, right? So it does those things, but the baroreceptors are what tells it. It sends a signal to the pituitary, and the pituitary sends a signal to them. Okay, so two things can happen. It can affect the vasodilation, that's a renin, angiotensin 1 and 2. Eventually causes vasopressors, vasoconstriction, and that, or relaxes it, but it's supposed to affect it. Or we can have, what's the other thing I just mentioned? Or the salt, the sodium, because water follows salt. So it knows how to do its job, and that's how it's going to regulate the blood pressure. Okay, so then we have excretes erythropoietin. What's erythropoietin? Red blood cells, right. So remember we mentioned with dialysis, we said when a person is on dialysis, sometimes the amount of blood that went through the system, it gets damaged. So when it comes back, it's a little less. So they give them epigen in order to tell the kidney, hey, you need to create more blood. So that sends a signal to the stem cells in the bone marrow to create more blood, but that's where the signal is coming from, okay? The erythropoietin is doing the signaling. So if we don't have that, we're not gonna have more blood. And remember, there was an oxygenation, we covered the COPD that turned pink. The pink puffer, remember? They're pink because they were lacking oxygen, and the body says, I know how you could get oxygen. Blood carries oxygen. Let's make you make more blood, right? And so that's why they turn pink, okay? So that's what erythropoietin does. It is signal from the kidney. Then we have converts vitamin D to its active form to absorb calcium, right? Do you remember where calcium is absorbed? Parathyroid, right? So the calcium is absorbed because of vitamin D through the parathyroid. But where does vitamin D come from again? The sun, right? So the person has to be exposed to vitamin D. So if the person is not exposed to vitamin D and they don't have good absorption of vitamin C, what will not happen? Their legs. They're going to develop a disease where their legs are like bow legs. Yes. What is that called? Yes, that's right, rickets. So I'll never forget this because I remember when they were teaching me this, they explained the little kids back in the day who used to work in the mines, they were still growing, right? But they would wake early in the morning and they would leave the mines late at night. So they would never have exposure to the sun, but their bones are still growing. So because of that, they would develop rickets. And that's how I don't know if that's how they developed or they found out that's what rickets is. I don't know. But I'd never forget that, you know? But yeah, so that's why we need vitamin D. And we need it through the skin, all of that. Okay, excretes water-soluble drugs and drug metabolites. What are like water-soluble drugs? What are some examples of water-soluble drugs? Vitamin K, vitamin D. Those are vitamins. Okay, let's talk about urinalysis, right? Let's talk about, okay, we're going to find out how do we know the kidney is working well? What are some diagnostics that we do? So urinalysis is one of them. So this one, several tests over a period of time are necessary. So we do radiologic tests. KUB x-rays is another one. Okay, but let's talk about urinalysis really quick. What are we checking with urinalysis? Yes, we're looking to see, does it have protein in it? Another thing, protein in what? Casts, that's another one. But proteins are the ones we focus on a lot. Why shouldn't there be protein in the urine? Something about reabsorption is supposed to be, it's not supposed to pass, but why? It's too big, right? So if something is wrong, that means the filter's broken. That's why it's passing through. Now, what does protein do again? What's the role of protein? It keeps. And it does it because it pulls. It's a pulling, oncotic pressure, right? Hydrostatic pushes, protein pulls. So it's supposed to pull the fluid and keep it in the blood vessel. So if it gets out, what is it going to do out there? Pull it the same way. And it's going to pull it outside, right? So we don't want that. That's why we definitely want to monitor, does this person have protein in their urine, okay? All right, so when we look at the gravity, the specific gravity, we're looking at the weight. We're looking at how heavy, how dark is this urine, right? How much electrolytes has been accumulated, how much has passed through, right? So then the measurement is 1.01 to 103. So when you think about 1.01, you're thinking about the lower the number, the lighter the urine. That means it's closest to water. Like if you are drinking water normally, naturally, all the time as you're supposed to, when you urinate, it's supposed to be light pink, Jesus. Light yellow. We don't want light pink. That means it's blood. That's another thing you don't want in the urine, right? So, tap. Yeah. Keep on. Thank you. Yeah, so you don't want, you want it to be light yellow, right? But if every time you pee from the very beginning to like, I don't know, who knows when, you pee like water, then there's not enough filtering happening and most of your toxins are staying inside. We don't want that either, right? So we want it in the range. But if it's like super, super dark, that means there's too much that's coming out that should be returning back, right? And we don't want that either. So we want it at the right. So it could be yellow, right? So when we are looking at urine, right, we say, how do we identify what we see? What do we say about urine when we're clear? What else? Cloudy, amber. Yeah. So if it's clear, that means it's normal. If it's cloudy, that means what? There's a UTI. There's bacteria in there. If it's amber, that means it's dehydrated. Yes. Or frothy. Yeah, that could be bad too. Definitely. There's casts in there, right? Proteins. Yeah. Okay. So we can check our urine, right? When we're doing so a person who had diabetes and you're checking their urine. What are you checking their urine for? Sugar, for glucose, and what else? Ketones. We don't want ketones. What are the ketones and how did they get there? Yes, the fat was being broken down. So what does that tell us possibly the person had? Yes, but what are they? DKA. They're coming in because they possibly, or we're afraid that they're going to have that. So that's why we're monitoring it, okay? So we don't want ketones in there. What else? We don't want blood cells in there, okay? If we have blood in the urine, What are we afraid of? What might be the problem? Kidney trauma, some kind of damage there, yeah. Or it could be thrombocytopenia issues, right? Whatever is causing. So we want to know, is a person on aspirin? Do they have thrombocytopenia issues? That kind of thing. But we don't want blood in their urine, definitely. We don't want it white either. Okay, we mentioned that. Let's see what else. So we want a clean catch, right? So how do we collect it? How do we make sure it's clean catch? What do we tell them? Okay, what else?
Clean first.
Yes, clean first, right? We want to make sure they have used that little white thingy. And then once we collect it, what do? Leave it on the counter. Come back. No, we put it in the fridge, right? If we're gonna get to it a little later, we want to put it in the fridge, because we don't want bacteria to build. Okay, so since we're on the topic of urinalysis, let's talk a little bit about the differences between men getting a UTI and women getting a UTI. Is like, what comes to mind when I say that?
Easier for females.
It's easier for females. Why is it harder for males? Longer eustachian tube. Eustachian. Urethra. Sorry. Yeah. So if a male has a UTI, what are we worried about? If a male has a UTI, what are we worried about? And it's a freaking one. What do we do? Okay. Yeah, definitely could be prostate. What's another thing? STD or STI, yes. Because it's very uncommon, so then we imagine that could be an issue. But since I mentioned eustachian tube, what do you think about when I say that? Who has longer eustachian tube? Grown-ups opposed to babies. So babies get more ear infections. Yes, thank you. Okay. All right, back to kidney. All right, so now we're looking at kidney renal function test. Okay, so what do we need to think about when we're doing a renal function test? What are we looking at? We're looking at our levels. Yes, we want to look at our BUN. We want to look at our creatinine. So we know that most of the time they have the range for you. So you don't have to memorize it, but it's good to know, right? Even in the hospital, you'll have your sheets and they'll have, this is the range, it's out of range. So you don't have to memorize it, but it's good for you to know what the ranges are. So the creatinine, the uric acid, what else? Okay, let's talk a little bit about KUB. What is KUB? Why are we doing that? Yes, it's a scan. What is it showing? Yes, the shape, the size, position, right? So we're able to visualize the tract. Okay, what's happening, right? If a person has prostate, we'll be able to see, oh, wow, the prostate is much bigger than it should be, that kind of thing. Yeah, right? Let's see, what else? So before we do a KUB, what do we need to make sure we have? Consent, right? We need a consent, right? What else? We need to restrict fluids because we don't want the bladder to be full, right? They do it with contrast. So what do we need to be careful with that? Allergies, right? So we want to ask them what? Are you allergic to shellfish and iodine? Let's say they say yes. What do we do? You definitely document and make sure the doctor knows. But a lot of times, right, they'll definitely have Benadryl on hand to make sure that if anything happens, that they can definitely use that, right? It's a huge risk, but if it's a mandatory, necessary thing, we need to make sure that they have it on hand. Okay, so let's see, what else? So sometimes it can cause flushing or warmth or nausea, so we need to inform them about that. Let's talk about renal angiography. What is that for? What are you visualizing? Yes, the artery supplies to the renal, to the kidney. Let's see, what else? So we're going to shave the area, okay, the groin or the ankle, whichever way they're going to put in the catheter. It's through a catheter. Make sure they void beforehand, okay? So since they're putting a catheter through the groin or the ankle, after the procedure, what do we have to tell them? Yes, no crossing of the legs. Yes. What else? Keep pressure, right? Because it's an artery, okay? Let's see, what else? We're also going to observe, like, what would tell us, oh my gosh, they need to go to the emergency room right now. Like, they need help. Like, what would they tell us?
Restless.
Not restless. Impending doom. Pain, excruciating pain. Because it's not supposed to be painful, right? They could have a little discomfort, but if there's swelling, if there's a hematoma forming, right? Or since we said ankle, we said groin, what else are we checking? Pedal pulses. We're checking. If we don't have pulses, they're going back because we don't want that, okay? And we definitely want to, because we're talking about kidney, what is the main thing we're monitoring to make sure that it's working properly? Urinary output, right? What's the level that it should be? How would we know? Oh, at least 30 mLs, right? Always want to make sure that they have at least 30 mLs. Great job, guys. Great job. Okay, let's talk about cystoscopy. What does that one do? We're inspecting what? The bladder and the urethra, right? We insert a catheter in there, okay? Why are we doing that? Usually it's because of what? What problem did they have? A stone, they could have a calculi, right? We want to see, what else? We could see the prostate as well, okay? Let's see what else. So they have to be NPO for this one, okay? Let's see. For prep, they might have to do enemas. Okay, so when we have any procedure that has to do with the stomach, what are some things that we are aware of that in our assessment later that we could be, like, that won't surprise us? Bowel sounds, right? So we want to make sure, like, we listen and auscultate, and we want to see, okay, is it low? Is it slow? Is it active? We want to make sure about that, right? And also, since we're on the topic, let's say the person had an incision done to the abdomen. What is one thing that we're worried about? Infection. What's another thing? Opening. Dehiscence. What's another thing? Pneumonia. Sure, pneumonia. But more so, like, what do you have to use? Splinting, right? It's painful because your diaphragm is right there. So you want to splint to help them to breathe, right? And then we're like, okay, you don't have the bowel movement yet. It's okay as long as they can pass gas or you hear those things, okay? Okay, what else? Okay, back to urinary. What is a sitz bath and why do they use it?
It's like constant flow of water.
It's used for why? Why is it used? For comfort, for it's comforting, right? So it soothes the pain if they have pain there. Who uses it a lot? Pregnant women. Yeah. Okay, so let's see. What else? Intake and output. Okay, let's talk about biopsies a little bit. So let's say they're doing a biopsy, kind of similar to all the other ones we talk about with cancer. What are we looking at? They're aspirating something, looking at it under the microscope. But anytime they aspirate whatever, that area, gotta put pressure, okay? So the goal, anytime they're doing biopsy, you want to, it's usually because they think something is cancerous, right? All right, let's see. What else can we talk about? Let's talk about, so pre-biopsy. What would they do pre-biopsy? What would they have to do? So it's a procedure. So anytime you go in to do a procedure anytime, what are the things we're making sure about? That it can be done. Like their vitals are okay, right? That, do they bleed easily? Do they, what is their clotting factor, right? Because you're puncturing a hole somewhere, you're aspirating, so you want to make sure, but you want to also make sure that they're able to do that procedure, okay? And you might want to do an x-ray before to make sure, okay, what location are we going? What are we aspirating, right? We want to make sure that's done too. And then after biopsy, usually the person, before their NPO, after their NPO. Let's talk about NPO a little bit. What does NPO mean? Nothing by mouth. So, and they're nothing by mouth because why? They're usually going to surgery, but what's happening? What are they taking that's making them general anesthesia, right? So now they come out, we got to make sure what before they start swallow test, right? We want to see gag reflex if they have it. And if they don't have it, they're not even leaving yet, are they? Yeah. So usually when they start eating, you want to start slow, right? Ice chips, clear liquids, that kind of thing, a lot of times, okay? Let's see. Prone, if a person is prone, what position are they in? Okay, So if you want to put pressure on an incision that was done somewhere, you want to put them on their stomach, right? Let's see, bed rest, checking their diet. What's a renal diet? What would it consist of? Low sodium, low protein, small frequent meals. That we can work with that. Low potassium, vitamins, calciums, right? High carbohydrates though. High carbohydrates. Okay. Let's see what else. So we're increasing their calcium. Hold on, let me. So we mentioned earlier, what did we say about calcium? We mentioned the hold on, let me check real quick. Hold on. I have vitamin and calcium here, but I do not have the reasoning here. Give me a minute. Yeah, so the filtration is not working properly. So some of the electrolytes are not going to be filtered properly, kept or released the way. So then, depending on the measurements that you find, then you add accordingly. Okay. Let's see what else. Low potassium. Let's see. Treat hypertension. Why are we treating hypertension? How does hypertension affect our kidney? Okay.
So the retention of fluid in the kidneys.
Yes, but also the pressure can damage the blood vessel, right? The same problem that hypertension can cause, what else can cause a problem? Diabetes, right? So it's damaging the small blood vessels or whatever blood vessels that are there, and once it's destroying it, it's not going to do its job anymore. Let's see, what else? Okay, let's talk about dialysis really quickly. Tell me, what is the goal of dialysis? We're cleaning our blood because the kidney's not doing it. So usually if they find after labs the urea, the creatinine, like the levels are too high, then they're going to say, okay, your kidney's not functioning properly. If the person's not peeing regularly, those are kind of things that will initiate a dialysis, okay? So we have the two dialysis, which are they? Hemo, yeah, and peritoneal, okay? So what are some of the things that we would do for hemodialysis? What are we looking at? So the person is, yes, right? We want to make sure, where are they getting it? Do they have a shunt? Do they have a graft? Do they have a anastomosis type something? Like, what do they have and how do I maintain it? Because I don't want it to clog. I don't want them to have to recreate another one, right? So, and I don't want it to be infected. So I'm trying to make sure it's flowing properly. So what are the things that would tell me it's viable? It's good. Thrill and what's the difference? So the bruit is a noise, bruit, right? It's French, I don't know, but anyway. And thrill is to feel like you feel like the excitement of the movement. So it's like a thrill, right? So, okay. So if you feel those things, that means it's working well. So they just came from dialysis. It's all wrapped up. What do? You don't do anything, right? Because you don't want to unwrap it to cause any bleeding. Let's say it's starting to bleed. What do? Pressure and add more gauze around it. Okay. Okay. So right before the dialysis, what are some things that you're making sure about right before the dialysis? You hold meds, right? Now the only med that we're worried about is what? Blood pressure meds. We want to make sure that they get those early so it can work, because if they have hypertension, we're not sending them. Okay, if the blood pressure is too high. Okay, so let's say they get there. What is the nurse going to do for them? Like, what's the process in starting the dialysis? What do they do? Well, yes, that too, sure. We want to weigh them, right? That's very important. We want to take their vitals, see what the blood pressure is, weigh them to see how much they weigh, because once they're done, then we're going to weigh them again. We're going to take the vitals again. The weighing, why do we weigh them? Yeah, so that's part of the reason why they go, because they can't filter it themselves. They can't get rid of their fluids. When I worked in this unit where this lady was diabetic, you knew she was ready to have dialysis. How do you think? swelling, her whole face, her hands, everywhere so poofy. She needed to be dialyzed because she was retaining fluid. So it makes sense that I'm gonna weigh her right before to see how much she weighs, and then I'm gonna weigh her after to see how much fluid I have taken out of her, right? What would tell me that I've taken too much out? Yeah, they can go into hypovolemic shock, and the blood pressure can also drop, sure. But they can also start having cramping, and that's an emergency. We want to get them to the hospital when that happens, right? So weighing is really important. Taking the vitals are really important. Usually, so it was a nursing home, they have a book, and then I would put all their vitals, and then I'll put the weight and everything, and then when they get there, they'll do it all over again and write it again so that they keep track, What else? Let's see. Okay, let's talk about peritoneal dialysis. What are some things that we need to know about that one? Right? So they can do it at home. It is gravity feed. So it's the same idea, but it's just fluid is coming into the peritoneal cavity. The same thing, the dialysate is a salty substance that has all these salts that, because waterfowl salts, it draws the salt. So, but the only thing, it takes time, more time. It needs to have a filling time where it has to be gravity too, right? It's up here, it goes into the stomach, the peritoneal cavity. Then we had to wait, let it do its job of pulling whatever it needs to pull. There's certain things it won't pull, right? It just pulls mostly fluid, right? And so then we need another bag to now dependent so that it can collect what is taking out, right? So what am I worried about with peritoneal dialysis? Infection, the same thing with the hemodialysis, right? But infection in the peritoneal cavity. So let's say they have infection. What would tell me they have infection? Fever, yeah. The area could be pussy, smelly, that kind of thing. Painful, it could be painful. Let's see what else. Level of consciousness could change too. I was thinking of something, it escaped me. Okay, it'll come back. So let's see. Weigh daily, monitor. When do we weigh them? Every morning, right? We try to do it with same clothes if we can. Definitely the same scale, for sure. Yeah. Do we restrict fluids? Yeah. Depending on how bad it is, you have to. I know the one lady, because she retained fluids so easily that there was a certain amount that once we were like, okay, you shouldn't be drinking.